I've been in wound management for 35 years. I started in New South Wales in community health and then progressed to the Gold Coast Hospital, working as a CNC there across the district, both in general practice, the hospital and nursing homes, and got a redundancy in 2012. And I have set up a secondary tier clinic working out of Bundall Medical Centre, whereby we were looking at a hospital avoidance program with a company called Wound Busters. So I'm a director with a GP there, and I'm also a director of the company called Debridement, which focuses on ultrasonic debridement, which is what we use in the secondary tier clinic in order to reduce the hospitalisation of difficult wounds. Now, all of the slides today have been collected by myself and Kerry Coleman, who's a nurse practitioner at the Royal Brisbane Hospital. And the wounds were either captured on the first day of through the emergency department or in general practice itself. So we're really focusing on early detection, diagnosis and prevention. Not a lot on wound products, but I'm going to be sharing what we use in our secondary tier clinic because it's really important for us to actually be mindful of how much we're getting our patients to spend on dressing products, and there are cheaper and easier ways to get outcomes that we found in experience. So let's get started. Ask lots of questions and as we go along, and the outcomes and objectives today are basically looking at changes in wound management in general practice, looking at early detection, early referral, identifying factors that may lead to delayed wound healing, and really focusing on common wounds that we see in general practice, largely skin tears. I don't tend to focus too much on burns, but I encourage you to look at developing a relationship with the burns unit that you use locally, and of course lower leg ulceration. So it's basically the lower leg that we mainly focus on. But we know in general practice that there are many and varied wounds, but the majority that we see are generally the venous leg ulcers and ulcers that are associated with some form of ischemia or edema. So we're going to be talking about that. There's more and more evidence that hospitals are discharging patients early back to general practice, and I also want to give you a few helpful tips on accepting patients from hospitals, because I do believe that as we're looking at early discharge, the hospital should also be supplying consumables. And when we're looking at pressure injuries that have been developed in hospital and are hospital acquired, there is a responsibility of the hospitals to supply those patients with dressing products until those wounds healed, and also follow through if necessary for plastic surgery referrals, and also to record. So I would encourage you to know what the Australian health standards say about hospital acquired pressure injuries, and follow those prompts quite quickly. And I know in Queensland I wrote the standard for pressure injury prevention and management in Queensland hospitals and community in 2011. I think it's probably been updated since then, but I do know that it was based around the health standards. So for us in general practice, we can accept any patient that the hospital sends us, but not all wounds on these patients are actually ready to start healing. They need to go through that inflammatory response, and that's where it costs money. So Carolyn Carville, a major leader in Australia, has come up with an item definition on wounds, but I would encourage anyone that's new to wound management to read some of Carolyn Carville's books. She's written a great book on wound management, healing wounds in the community health, and it's very affordable, and the funds go to Silver Chain. So do a wound search on Carolyn Carville's book. Now, most of our presentation today is based on what we've actually derived from the Beach study and what we've seen in our secondary tier clinic. And we know that in general practice we manage a lot of patients with wounds. Wounds generally aren't that complex. It's the patients that the wounds are on that are complex. And I'm going to be talking a lot about that today. Looking at nursing homes, we need to be aiming at quality of life for all of our patients, and that may not necessarily involve healing, but we can certainly reduce pain and we can look at comfort levels. But the most important thing that I see here that we really want to change are the number of referrals. So in the last Beach study, it showed that only 5% of patients with a wound were actually referred to a secondary or tertiary medical officer. Now, latest research is telling us that, particularly with the diabetic foot, we should be using more of our case conferencing. because once the patients have a wound on a diabetic foot, that may be the stimulus to actually lead to the cascade of renal impairment later on in life. So it's really important for us in general practice to actually look at the way people walk, look at the changes associated with diabetic feet, and prevent these wounds from occurring at all. Because the cascade down the path of an infected wound, 50% of patients with an infected wound on a diabetic patient will be dead in 1 year. So we need to really look at that. Globally, the tsunami is coming. One patient every minute in the world is with diabetes is having an amputation. In Australia, one patient every 2 days is having some form of amputation associated with diabetes. And of these patients, 50% are going to be dead within a 5-year period following an amputation. So we can do great work in general practice by early referral. Vascular surgeons have been found in a study that's just recently been out of the States that a venous leg ulcer, which generally heals in 12 weeks with compression, heals much more rapidly if these patients are actually referred to a vascular surgeon and have endovascular treatments as well as compression garments. They heal in an 8-week or earlier than 12 weeks. In our secondary tier clinic, we found that applying compression and getting the results we needed, we generally see venous leg ulcers healed in 8-week period turnaround. So looking at the beach study again, we see a lot of these things that we need to actually change. We need to change the number of skin swabs that we're doing. A lot of the wounds that are actually delayed in healing that we call chronic wounds, and a chronic wound is a wound that's trapped in the inflammatory response and is associated with biofilm. Now when you look at a skin swab, we need to know that we're getting the organisms that are causing that wound to be delayed associated with biofilms. Biofilms sit 0.3 to 0.5 of a centimetre underneath the surface of the wound, so a swab is not going to get that. So we need to know the proper way of getting the organisms, and that's the Levine technique, and I'll talk about that later on. We also need to look at stop focusing on the dressings that we're putting on and focus on the whole patient. This is something in general practice that we need to do. Now, something that's really important at the present time is that the Medicare task force is actually sitting and looking at item numbers in general practice. So I would encourage you as nurses to talk to your GPs about contacting the Medicare task force review panel. That if you do a search, there's an email address that you can actually write things. We don't have a generalised debridement item number in general practice that we can use with topical lignocaine. There's an item number, 30023 and 30024, that we use with blocks and general anaesthetics that is $266. But for regular debridement, mechanical debridement, we need an item number that we can apply lignocaine, because this is something that is not being done in general practice that leads to wounds not healing. So please think about that. Now, the beach survey showed us that not only were we not referring patients, we're not actually properly diagnosing wounds. And I would challenge you as nurses that if you don't have a proper diagnosis of a wound, you shouldn't be dressing the wound at all. You should be working with your GP to determine what is causing this wound to be there. Okay, we can see that only 16% of the wounds had a proper diagnosis, pressure sore or venous. Now, venous 10%, we know that venous leg ulcers in general practice are up around 80%. So we can see that leg ulcer here that's not properly diagnosed, or unspecified skin ulcer, and foot ulcer could actually mean diabetic, neuropathic lesion associated with pressure, or it could be an ischemic associated with blood flow. But unless you've got a proper diagnosis, how do you have an outcome-based plan that's actually centering around case conferencing and working on other aspects of care such as physiotherapy, sports physiologists, occupational therapists, and podiatrists? So I'll be talking about that and challenging you as we go. We know that a lot of the wounds that we are looking at don't have wound duration. And I work in a vascular clinic with a vascular surgeon, and a lot of the wounds that we get have had a duration of 10 years or more. So these patients are living with wounds that have been 10 years in duration. And we know in Queensland in particular that venous leg ulcers that have been there longer and unhealed after 6 months are at greater risk of developing squamous cell carcinoma and turning into a marginal cyst. So that's even more importance for you to think, if a wound is slow to actually change and is not progressing in healing, you need to actually look at doing a biopsy to determine whether you've got organisms down there, 0.3 to 0.5 of a centimetre under the surface, but also to look at, is there cancer in situ? And I'll be talking about the signs that the body shows you that the tissue is just a little bit different, to actually think we need to get a biopsy on this. Okay? So, when we look at a wound, what do you think when you look at a wound like this? This is a patient, first day of referral into the hospital. That's not a wound that should have been managed in general practice, is it? It's actually got exposed tendon that's actually quite fibrinous, and you've got the vessels on display. So one thing that you would actually think about this patient is that they've come in too late to the general practice, they've refused admission to hospital, or they've actually been doing the dressing themselves. It's nice and clean, and a lot of our patients are using these aberrant dressing products that they've had for 15 years. There's still that EDF powder is still being used and valued in the community, isn't it? So we need to know that, when do we refer on? A wound like this doesn't heal with dressing products without a great amount of expense. So there is still a plan to actually send these patients off for skin grafting and close that wound so the patient can actually get back to a quality of life. So not all wounds we're trying to avoid hospitalisation, but planned hospitalisation is the way that we should be looking at in the future. So how does healing occur? The first thing that the body does when the skin is injured is what? It tries to stop bleeding, doesn't it? It tries to form a clot, and the body wants to survive. It does not want to bleed to death. So really, the first function that we should be thinking about when the patients come in same day, when the wound is still bleeding, which is very rare, isn't it? They usually come in day 4 with dried toilet paper and tissue paper and all of that on the wound, and we take it back to that inflammatory phase or back to the hemostatic phase if we cause bleeding again. So it's at this phase that we need to think, okay, we need to stop the bleeding. But sometimes these patients are on medications that interfere with the clotting cascade, and we need to use something like a little bit of silver nitrate to stop that bleeding, a bit of pressure, sometimes even just getting a little bit of a forceps and just holding onto the bleeding area until it stops bleeding. We also need to look at if we're using products that actually stop the bleeding. There's a great product out at the present time called Blood Stop, and it actually is a great hemostat that's really quite affordable in the community. So look out for that. But when it rapidly absorbs into the body, so you don't need to remove it. But that's the same thing that Caldesat said. Remember the early days of Caldesat, they said you don't have to wash it out of the wound, just leave it there, which we did, and then we found these big mounds of alginate that was underneath that overgranulated tissue. So, I'm still waiting to see if that's correct. But anything that you put on, think about the nurse that's actually taking it off. Because if you leave a Caldestat on and it's full of blood, and you leave it in place for a week, what's going to happen after a week with Caldestat that's got blood in it? It's going to tear and cause bleeding again and take that fibrin clot out. So we need to think of ways that we can actually remove the dressing without causing it to bleed again. Maybe thinking about an inert substance in between the wound and a Caldestat, a Mepitel, for example. You put that in between, you still get the calcium and sodium exchange from the dressing to the wound base that stops the bleeding or reduces the bleeding, and then on day 3 to day 7 when you remove it, it's not going to cause bleeding in the future, because we know that the Mepitel can stay in place for up to a week to a fortnight and does not cause any damage on removal. The second stage of wound healing is the inflammatory stage. Come in, ladies, up the front. I'm Cheryl. So this is the phase where we are actually, the body is deriving all of its fast flow. It's wanting to get rid of the organisms that have been injected into the wound through the injury. It's trying to get rid of the damaged tissue. So it's autolysing damaged tissue. This is the phase that's associated with lots of exudate, because you get a lot of swelling in the inflammatory response, and the wound base looks quite sloughy because the body's doing its job, getting rid of organisms. It's actually getting rid of damaged tissue. So this is the stage that we need to focus on as far as enabling that phase to actually go through from the inflammatory phase to the proliferative phase. What is the key nursing clinical initiative that we can do in this phase? Oh my God, have you all been drinking? Did you all drink last night? And you're just very quiet, or am I a little bit too intimidating? You manage the exudate? That's a latter part down the track. You actually debride, don't you? Because that's what the body's trying to do. It's fighting organisms. You're debriding the wound. Now, if you're not actually competent with your skills as far as sharp instrument debridement, you can actually look at a cheap way of debriding a wound. But the key thing in this phase, when you've got a lot of swelling, a wound is going to be really painful. So we use lignocaine 5% on this wound. The patient can buy this from a chemist. It's scripted by the GP, so the GP has to actually organise this. You actually can draw it up in a syringe and then take it to the wound bed, put it on the wound, wrap it in Glad Wrap, get the patient to sit outside and wait for 20 minutes. And that wound will be completely anaesthetised. And if you're going to debride it, you can also put a little bit of gauze with Prontosan over the top or betadine to kill the organisms as well as reduce the pain. Wrap it in Glad Wrap, the patient comes back in and you can debride. Now, in our first instance... Please, yes. It doesn't squirt, it's actually a thick so an will actually penetrate deeper into the adipose tissue.
And I think while I was reading that, I heard you say something about...
antimicrobial reduction.
Some other product you were using.
Prontosan.
Yeah, that was right. I couldn't hear you.
Good. Okay, so Prontosan, it's spelt Pront.
I know what it was.
Oh, good.
Sequence. I stopped listening completely after.
Good on you. So we want to actually, in the inflammatory phase, we want to get rid of the dead tissue because we know that's what the macrophages are trying to do and the neutrophils are trying to kill off all the organisms. So we want to do the same thing. We need to mechanically debride. And sometimes when we get our patients into the clinic for the first time, we can just get a betadine sponge, if the patients aren't allergic to betadine, and wash the limb down from the top of the knee down to the foot. Whenever you're cleaning a limb, you need to go from the top of the limb down. If you go up and down, you may develop folliculitis because it's actually going up and down against the hair shaft. So if you go from the knee down, you're going to reduce folliculitis. We wash the whole leg with betadine. And the most important thing with any of our antimicrobials is the contact time to kill the organisms. It's not just enough to just sluice the wound with a solution. You've got to have the solution that's an antimicrobial on the wound for at least 10 minutes for it to heal. And this is a really crucial element. Whenever you see your first patient, the patient for the first time is to clean and remove all of the debris from the wound. So the sponges that the surgeons use to wash their hands pre-operatively is what we do. We peel the plastic off and we just wash the leg down with that. And we wash the wound with that and we leave the soap suds on the wound for 10 to 15 minutes to kill the organisms. And then we flush it off with saline. Because at the first sign, you're not actually going to start healing. Healing occurs when you get rid of the organisms and you reduce the dead tissue. So we as nurses in general practice have to think, we don't want to use expensive dressing products to kill the organisms. We need to use our nursing skills. And that's what we're very, very good at. Okay, so that's what happens in the inflammatory response. Now, when you've got a wound in the inflammatory response and you've got increased exudate levels, you're not going to get full value out of using expensive dressing products that need to be there for 3 to 4 days to 7 days. Because when the exudate's high, you need to change those dressings daily. So why not just use cheap products like Mepor or standard combines with plastic on the outside that the patient can change themselves? So that's something to think about. What phase of wound healing are we at to determine what cost of dressing product you're going to use in that particular phase? As the wound is tipping from the inflammatory phase to the proliferative phase, you start to see little growing, budding granulomas coming up. So the wound changes from a sloughy, yellow, exudating wound to a wound that the exudate levels start to dry off, the amount of peri-wound edema starts to reduce, and the base of the granulation, the wound base becomes granulating. So it's a nice red wound. If you don't have an even coloured red, and you have an association with bleeding or with odour, you may have anaerobes in situ, particularly if you're using waterproof dressings. So if you take a waterproof dressing off a wound and you see that the granulation is purple and you're associating it with a little bit of a smell, you may have some gram-negative organisms in there or anaerobes. So you may need to think, okay, I'm going to actually wash this wound, give it a good mechanical debride. You get your cleaning equipment, come back, and the wound's been exposed to the air and it's now red. That's a key sign to you that the anaerobes have actually been reduced in number just with exposure to the air. So you may need just a cheap dressing product that allows a gaseous exchange rather than a waterproof expensive product to kill the organisms that are in that wound. So in order to get rid of the organisms, we've got to make the wound bed less attractive for those organisms to stay. Okay, so know what your organism's like. Pseudomonas loves a really moist environment, so if we can dry a wound out and hit it with a broad spectrum antimicrobial like betadine or prontosan or acetic acid, you'll kill the organisms, and then you'll lead the wound to actually proliferate much quicker. Okay, which then reduces the cost of the dressing products. So you've always got to determine the quality of the granulation. Another thing about the granulation can mean if you've got bleeding granulation, it can be the first sign that you'll see about the patient being malnourished. You ask the patient how their weight has been going. If they've lost a lot of weight, that can be a sign that they're actually reducing the protein in their diet. And in your manual, I noted today that Nestle are advertising arginate, which has got a lot of evidence base behind increasing the protein levels in order to heal the wound. Now, this company in particular, I don't know if it's got a stand here, but if you contact them, they will send samples to you and you can deliver them to the patient, because they can be quite expensive, but if the patients like them, they'll buy them themselves and it makes a difference. So bleeding granulation can be one of the first signs of infection, but it also can be malnutrition. We know from a study that was conducted in 2005 or 2006 by the Royal Brisbane Hospital that 50% of patients with wounds entering hospital, 50% of all patients entering hospital are malnourished, even before entering hospital. Now we know that our aged care and our superannuants are now suffering because it's expensive to live. So what's the first thing that nursing homes do to save a bit of money? They reduce the protein and increase the carbs. And that's what our patients are living on, lots of carbs rather than protein. And that really hinders wound healing. So we need to actually look at the quality of the granulation. It needs to be an even red. If you've got a red granulation with pockets of purple, you need to actually give it a good clean and get rid of the anaerobes. You need to think about organisms there. If you've got bleeding granulation, where you just take the dressing off and it starts to bleed, think malnutrition, think first signs of infection, and you need to mechanically debride that wound and kill the organisms. And once that wound starts to heal and proliferate, the fibroblasts that are used in this phase of wound healing become myofibroblasts, so they contract. And this is when the wound, if you have prepared the wound well, you leave your dressing product on for a week, you'll see that that wound actually contracts quite efficiently in that last phase, or the remodelling phase, where you're going to have epithelial migration. And as we go through this talk today, we're going to be talking about how the body shows you that you've also got the beginnings of epithelial migration, because the granulation starts to change colour. Healthy granulation is beefy red and moist. In the latter phases, where you're starting to get skin cells migrating over, you'll start to see areas around the edge that maybe look a little bit dull in colour, and you may just have one layer of skin cells. And then the one layer of skin cells migrates up to form skin after it's got 5 layers. Sometimes when you aggressively clean a wound, if you see this clear film going around the wound, that's the stratum basale, or the first layer of skin. And if you just put it back onto the wound surface, again, because it only adheres to the granulation, it floats, it doesn't attach. You can attach it back just like a skin graft, and skin migrates up and forms different shapes as it goes along, and the different shapes of 5 layers form a barrier against infection. So that's healing in a nutshell. Wonderful, isn't it? And we can make a great difference.
Sorry, can I just ask?
Yes.
How do you do that layer?
It's when you actually are moving it around, you can actually see this clear layer move around. You just spread it out and just leave it anywhere in the wound that's healthy, and it will hold in place eventually. Because you just want to put a dressing in place, leave it for a week so that it's got time to for the cells to migrate up. Okay.
Does that concept transfer to silicone with burns? Patients, you know how they have silicone?
Absolutely.
How that works? I don't know.
Well, the silicone with burns is basically stopping the skin graft, because burns are just well managed in burns units. The surgeons cut the dead tissue out. They then put a silver dressing on to stop it from getting infected, and then they skin graft it a week or two later. And this is really important for us in general practice to know that silver products don't work well in a sloughy wound, because a sloughy wound is always alkaline in base, and silver products actually work in an acid base. That's why they work beautifully in burns units after the surgeons have actually cut all the dead tissue out, because it's a nice acidic base and the silver will work. So always think about that. A much better dressing product to use if you've got sloughy infected wounds is iodosorb, a slow release cadexima. Or what's an old school dressing product that will kill? It's the Arnie Schwarzenegger antimicrobial. You've got a painful wound, you get something out of the fridge, you put it on the wound and the patient goes, oh, that's lovely. Flamazine. It's great, cheap as chips. It dumps silver 1,000 parts per million. But you don't need Flamazine on a non-infected wound, do you? You only use it for the first 3 days, get rid of the organisms, and then progress through the proliferation stage. So always think about that, and think about what outcomes are you hoping to achieve by your dressing products, and are you case managing these patients? So the classification of wounds is really important for us. We need to know the duration. How long has it been there? How long hasn't it been healing? Because we need to do a biopsy. We need to ensure that it hasn't got cancer in situ, and we need to know that we're getting the organisms underneath the surface of that wound. We need to know the depth so that we know what artefacts in the tissue are actually going to be missing when the wound heals by secondary intention. We need to think, if a wound is down to the bone or to the integument into the arteries or veins, you need to refer that early and have it skin grafted, because it's going to take a lot longer to heal. And you've got to know, if you've got a wound, particularly on an area that's used a lot, that a wound is going to be 20% weaker when it heals by secondary intention. And this is really important for the diabetic patient, particularly if they've got a heel lesion that you're walking around in shoes, because that part of the wound will actually be at risk of breaking down more regularly. So sometimes you may need to actually think about silicone socks in a healed diabetic wound further on down the track. Or in a patient with spinal injuries where you've got a pressure injury on the sacrum, you need to think about getting that wound healed and then referring them to a plastic surgeon for a flap repair, because the healed tissue is 20% weaker, so every time they sit in the chair, it's just going to break down because the tissue is only scar tissue. Okay? And looking at the wound colour, because it tells us, as I said to you before, what's healthy and what's not. Another thing that we need to look at is this an acute wound or is this, a chronic wound? If it's been there longer than 4 weeks without healing or without changing, you've got a chronic wound. And that's when you need to actually think, do I need to send this to a secondary tier clinic or to a nurse practitioner? Or is there a GP in your local area that actually has an interest in wounds that can actually tip a wound that's chronic into a proliferating wound? And I'm all about encouraging PHNs all around Australia to develop secondary tier clinics. One PHN should have one secondary tier wound clinic in it, so that nurses in general practice and GPs can actually send these wounds to the secondary tier clinic without sending the patients into hospital. We need to be reducing our hospitalisation, because most of our wounds can be managed. Now, when we look at this top wound, what does the story tell us with that? The age of the patient generally. They're generally young. How many of our tradies clean their tools? Filthy work environment. They always tell us they're not going to go to work, but do they go to work the next day? My oath, they want to get away from their mothers. Our job as mothers is to get them back to the workplace as quickly as possible. So we need to look at this and think, okay, it's close to the heart, the granulation is healthy, it's a skin tear caused by a filthy machinery, so we need to give it a good mechanical debridement. What young man is going to let you scrub a wound They're not unless you put an anaesthetic on it. So you put your lignocaine on that, wrap it in Glad Wrap, they come back in, they let you wash it, or they can wash it. All you need is the chlorhexidine sponge or the betadine sponge, and they can do it. And then you actually need to put an antimicrobial on a wound like that, because you know the environment's dirty. And then when you actually finish, you've got to actually manage a little bit of the swelling in the finger, because the fingers will get swollen. So a little bit of 2 layers of tubular bandage, put on that will manage the edema. And then give them a whole set of gloves that they can cut the finger off when they go back to work and protect that wound from actually getting infected. So we know that we've put an antimicrobial on the dressing. We've put a dressing that's not going to cause pain on removal. We've covered it and protected it against infection. So we've prepared that wound to actually be left, the dressing to be left in place for up to a week. So when the patient comes back in a week's time, the majority of that wound that you can see here, you've got, if you look at that, you can see that granulation here, you've got a little bit of skin remnant left there. So that will all be healed in a week's time. This area, we've actually done an x-ray to ensure that the bone isn't involved. That will probably be the size of 2 millimetres by 3 millimetres after you've left it in place for a week. Oh, isn't it? This is... I need to do that and smile at the camera at the same time. So, okay, it's working there. Okay, sorry about that. So you can see this remnant of skin here. That's 1 or 2 layers of skin cells that after you leave it for a week will have 5 layers of skin. So that will all be healed, and you'll just have a little wound there where it's deeper, where it's going to take a little bit longer to heal. I always use iodosorb, and we draw it up in a syringe and apply it to the wound, whether it's a powder or a paste, that way. And there's a new paper out that was designed through Wounds Australia that talks about reusing products again. Aseptic technique, if you look at Wounds Australia on the website, there is a document there on aseptic technique, and you've got guidelines as to how you can reuse products again in general practice, because you need to use it appropriately so that you're not going to have infection caused by using the products, cutting them up in a non-sterile environment and then causing cross-infection. Now this wound is telling us a different story, isn't it? It's not acute, but it's chronic. Now, when I'm going through this, I'm going to be talking about what the body is telling us. So what are the things that you see that are a little bit strange about this leg? There's a lot of edema. There's staining around the outside, isn't there? But the wound base itself is quite granulated. There's a little bit of slough that may be actually less than what you did before or more than what you did before. I would say that they haven't, you can see on the leg that there's been no compression on that leg. So the slough may be getting worse before it's getting better. And this is not necessarily a problem associated with our technique. It's more to do with the patient taking it off at home. So when you actually look at a leg that's got a lot of edema and you've provided the patient with compression, you actually have striations from tubular bandage that you know that they've been using it. If they haven't been using it, you'll have a lot of striations, but a lot of the fluid has been pushed out and sitting on the skin. Now, the plumbing associated with the lower legs is all about getting nutrition down to the cells and then getting rid of cellular waste from the body. So the venous system is all about reducing cellular waste in the lower leg. And as we age and we've had, a car accident or we've had babies and developed a DVT, sometimes our veins start to get a little bit damaged. And the valves that are designed in the veins to actually have a one-way system allow it to be two-way. So the fluid that is meant to go back up to the heart and then excreted through the lungs and the kidneys is actually sitting in the tissue. So when that tissue is filled with venous fluid, it becomes venous hypertension. All of the pressure inside the veins increases and the fluid then sits into the tissue. And when you get venous fluid in the tissue, you've got cellular waste sitting in the tissue. And a really important point for us to think about is that when venous fluid sits in the tissue, you have hemoglobin in the tissue, and this turns the tissue brown, okay? In the early stages, it may be red, And a lot of people, when you've got swelling of the limb, think it's cellulitis. So the way that you actually tell the difference between cellulitis and venous redness is to actually elevate the leg for about 5 minutes. And if the redness goes, it's all about venous dependency. If the redness remains the same, you probably have a little bit of cellulitis. So you really need to actually think about, is this wound actually infected? And I talk about infection later on, so we'll be going through that again, but we talk about these wounds as we go. So another thing that we see is when you've got fluid like that sitting there, whenever you've got haemoglobin that's been pushed out through into the tissue, through the veins, you've also got fibrinogen. Now, fibrinogen forms fibrin deposits around the ankle, and the ankle area can get really woody, and the patients stop walking normally. So it's something that we really want to take notice of is our range of motion, because our range of motion will tell us what level of compression is going to work for your patient. Elastic dressings, elastic bandages aren't going to work as efficiently in a patient that's got reduced range of motion. And whenever they've got fibrinogen sitting in the area, they need to actually stimulate their calf muscle to work, to push that fluid back up to the heart. But if they've got an ankylosed joint, they're walking like this. So we need to look at how the patients are walking, because that will determine what type of bandaging system is going to work for that patient. Okay? So we need to look at these patients and look at the signs and symptoms and think, okay, we need to get a sports physiologist to get that patient to do bending exercises to stimulate that calf muscle pump. The patient needs to walk up and down stairs, because when we walk up and down stairs, you'll actually get the calf muscle working. If they've had a road accident and they've got an ankylosed joint, you need to use non-stretch bandages. Something like Comprolan will do the job there, because it will actually get rid of the fluid without actually using the calf muscle pump. So there's a whole range of information there. Now, when we apply compression to a leg that's got a lot of edema on it, the patient rocks up in the afternoon. What's going to happen if we leave the compression on for a week? All of that venous fluid is going to squelch out through the wound, isn't it? And it's going to sit on the peri-wound area. So we know that the wound fluid is full of cellular waste. It's going to excoriate that tissue. So we need to get rid of the edema slowly. And one thing that I do is I say to the patients, you've got a large leg there. I measure the area just above the malleolus, and then 2 centimetres below the knee, 2 fingers below the knee. And then I give them 3 layers of tubular bandage. First layer from the base of the toes to the base of the knee. Second layer from the base of the toes to around the mid-calf area. Third layer from the base of the toes to just around there. And I say to them, take this home, and in the morning before you get out of bed, put your compression garments on and come back and see me first thing in the morning. And sometimes you can have a centimetre reduction of 6 centimetres in that ankle. And you've got that patient engaged, because patients generally aren't aware that they can actually do anything about that level of swelling. Now, it may not be enough compression to heal the wound, but you'll get the reduction slowly, and then you can go on to bandages that can be left in place for a week at a time without causing injury. And you can also give the patients combines so they can change their dressing regularly, so the fluid is not going to sit on the skin around the wound. So they're just techniques that we use to get the patients involved. Now, when we look at acute wounds will tell us whether they're healing or not healing. Okay, so a suture line, still got sutures in it, preparing to take them out. We know this is probably day 7 to day 10. What does that wound tell us? It's actually healthy. It's actually following a healthy trajectory, because suture lines should be healed after 3 days. Okay, so you can see the area of incision. It's all nice and dry, and you've probably got epithelium right along it. But it requires compression, because there's still a lot of fluid in there, isn't there? I call this the Sharpay effect. When you've had a little bit of compression and you apply compression, you get this wrinkling in the skin. It's working. But this area here still requires more compression to get rid of the excess fluid that's in there. So once we remove the sutures, we need to actually remember to keep applying compression. Those patients want to get out of compression as quickly as they possibly can. But we need to tell them that if they aren't wearing compression and the fluid builds back up because of gravity, the fluid will actually leak out through the suture line. And why is that? The suture line is 20% weaker than the tissue around it. So they need to wear compression. And whenever you take the sutures out and the wound is healed, you tell the patient, wear compression so that the fluid doesn't leak out. If you notice that the fluid is leaking out through that suture line, come back and see us. We need to give you more effective compression. What does this wound tell us? That's a foot, so that's the heel there, and the toes are up this area, and it's a graze. What things can you see there? Thanks for drinking last night, girls. It's always good to go away, isn't it? But, you know, you've got to actually look at this foot and you see a swelling, okay? But not only that, this occurred a couple of days ago because you've got a little bit of that wrinkling in that foot, but you've got a satellite lesion down here. And if a superficial wound is really, really painful, you need to think this could be some sort of autoimmune response. And what's one of the most common autoimmune responses that we see in general practice associated with trauma or surgery when the wound just doesn't start to heal appropriately and the patient's got inordinate amounts of pain? Think about Pyoderma Gangrenosum, okay? And this wound may need to be sent to a dermatologist early rather than later because it will deteriorate really rapidly. And sometimes the first cause is trauma or surgery on a patient that previously hasn't actually shown signs of Pyoderma gangrenosum. And it's always predicted by satellite lesions occurring around the wound being extraordinarily more painful than a normal wound will be. Think, this isn't normal, what do I need to do? Send it to a dermatologist and they need steroids. They don't need expensive dressings, steroids. Now this wound, what's this wound telling us? It's an elderly patient, it's a resolving skin tear, but they didn't put compression on this arm when it was first injured because they brought the skin back beautifully, they removed the hematoma, but they didn't manage the edema in the arm, and the swelling caused the skin flap to pull away from the edges, okay? Because we know with the phases of wound healing, when the wound is first injured, it starts to bleed. The second phase then is the white blood cells come in and break down dead tissue. So they try and get rid of the hematoma. And if we haven't removed the hematoma, that's what the body will do. So you'll get swelling, and the swelling will cause that skin flap to actually pull away. So you've got a wound to heal. Whereas if you managed it with compression from one end of the limb right up to the other and treat it like a skin graft, you will have that edge being attached to the margin simply because you've reduced the edema as early as possible. Now, plastic surgeons will tell you, all you want to do with a skin tear is just attach the skin. You don't need expensive dressings to do that. You just need to bring the skin back. Think that the skin has no blood flow of its own, it derives all of its blood flow from the dermis. If you clean that hematoma out from under the skin flap, if you manage the edema and you hold the skin in place, that's going to take. So let's look at these wounds. These are showing signs of chronic disease, aren't they? Now when we look at this wound, it's been there far too long. It's been there longer than 4 weeks without actually getting better. It's actually getting worse. You can see this dead tissue here. But you can also see the granulation is really gelatinous. When you've got overgranulation like that and you've got edges that are undermined, you need to do a biopsy because cancer in situ will display those signs and symptoms. And if you look at the patient's leg, there may be other signs of solar keratosis. The patient's history will tell you that they've been on the beaches, they've worked in the Surf Lifesavers Club for 30 years. So they're at great risk of solar damage. When you get a wound and the wound's been there longer than 6 months, you may have a marginal cyst. So you need to actually take a biopsy and determine whether you've got cancer in situ. If you haven't, that's great. Let's just compress that wound. But we can see that there's been some form of compression there because of the Sharpay effect, can't you? You can see that? Can you see that? Okay, so they're the signs that you look at. Unhealthy granulation, dead tissue, because that slough isn't caused from infection. People get really excited about this sort of slough and add moisture to that wound to get rid of the slough. But that slough is caused by the moisture draining through the wound, so it doesn't need more fluid there. And if you add more fluid to a venous leg ulcer, you're actually creating an environment that's conducive to Pseudomonas. It loves a moist environment. And how often do we see our venous leg ulcers become contaminated with Pseudomonas? So we need to dry it out. and we need to actually get our compression working a little bit more efficiently. This wound is a pressure sore. Now, no matter what dressing products you put on this wound, the wound will continue to break down until all of the damaged tissue has been removed. Okay, now patients that are at risk of reduced white blood cell function will be locked into an inflammatory response, and they need to be debrided. So a lot of these wounds require plastic surgeons to cut that dead tissue out, flap it. But there's a lot of patients that we see in the community that aren't surgical candidates. But if they've had a pressure ulcer that's been caused by a nursing home or a hospital, the hospital or the nursing home should be supplying the patient with the dressings. It's a litigious ulcer. So we need to think, is this patient a diabetic? What happens with the diabetic patient in the inflammatory response? Your white blood cell function is reduced. So the white blood cells in a patient with a diabetic aren't competent enough to actually fight off organisms and to actually get rid of dead tissue rapidly. That's why we need to debride those wounds rapidly. We need to detect them early and we need to get them healed, because we know that a wound on a diabetic patient is going to be trapped in that inflammatory response, and the proteinases that creates in being in the inflammatory response lead to renal damage. So we need to protect our patients from developing renal damage. We need to look at all of our patients with diabetes early and look at whether they've got functioning kidneys, whether their eyesight is good. And we need to know that before they get a wound. And we need to be horrified when patients get a wound. So when we look at our patients with care planning, we need to look at, this patient has diabetes. Is it at moderate risk? Is it at high risk? Or is it at catastrophic risk of death? And this is what we need to think. No diabetic is at low risk of developing a lesion in their feet. So don't use low risk anymore. Medium, high, catastrophic. And we need to then look at when we get them back in to actually do that full scope of change, to evaluate what we've done. So with a diabetic, for example, or someone with rheumatoid arthritis, their white blood cells aren't functioning. Someone with cancer, they're neutropenic. We need to get them in regularly to check and to do, our care planning and evaluating whether our care planning has been efficient and has led to the wound changing. This wound here, what do you think about that? It's quite unusual, isn't it? We don't see a lot of wounds at the back of necks unless they're cancerous. Now, this is a melanoma patient. Unfortunately, it's a young patient who refused to go into the GP early. How often do we see these lesions that they've just been managing too long? This patient died a number of months after this because it had already actually spread. So we don't keep cleaning it out. We get that patient straight into the hospital because they need to be debrided and look at the level of management that they need from cancer specialists there. So yes, all of that area around there is warning us that something is happening there. Look at the peri-wound. Is it normal and healthy? That's not healthy tissue, is it? So, acute or chronic? Good. You think so? Often on the Gold Coast, even in the winter, we get these patients that put their feet too close to the heater, and the only time that they know that the heater is actually too close to their foot is they smell burning tissue. Now, a number of these patients that come in like that, that's a warning sign. 70% have got neuropathy that have diabetic changes, but sometimes they have the neuropathy before they're actually diagnosed as a diabetic patient. So when you've got patients that can come in that say they're walking on, oh, look at this, I had a drawing pin in my foot, just found it, but it's not hurting. You've got to think, okay, this is neuropathy. This patient has probably got the early signs of changes to their vessels. In diabetes, you have calcified vessels that aren't compressed. So when you do an ABI, do you all do Dopplers here in general practice? Because there's an item number for that. There's a group here called Team Medical. They've got a stand and they're going to have a bed, a table, and they're going to show you how to do ankle brachial indices with a Doppler machine. Now, ankle brachial indices are really important for the 50-year assessments. You know, you pick up your smokers that have got some form of ischemia that can actually be treated with just radiological interventions rather than fempop bypasses. Get them referred early. You get these patients without positive changes in their renal impairment that have got changes in their tissue in the lower leg associated with edema, mixed with ischemia. This man lost his toes even before he was diagnosed with diabetes because of the changes in his legs. So when you do an ankle brachial index on a patient that's got calcified arteries, your reading will be a false positive. It'll be 1.3 because the calcium stops the vessels from being compressed. So if you do that at a 50-year-old and you've got arteries that are 1.3, 1.4, you need to think, okay, this is a patient that's at great risk of diabetes. So you'd do a care plan on that, and you'd see them regularly and you'd teach them how to care for their feet to prevent this sort of action from occurring. But what's a test that you will do? A Sams-Weinstein filament. And if you look at the RACGP guidelines, it will tell you about how do you, a tool for assessing feet in diabetic feet. So look at that tool and do it regularly as part of your care plan. And that's detecting people early who are at great risk of a chronic disease. How wonderful for them to be picked up at 50 rather than at 60 when they've got the large vessel disease. So always think, this is not normal to have someone coming in with a burn. Or worse still, someone, you know, at Christmas time who's walked across the road, the bitumen road in the heat, and they've got all of the bottom of their foot burnt. You can't walk across a bitumen road without it causing you pain, can you? So if you're walking across a bitumen road and you get 3rd-degree burns, you've got some sort of sensation that's allowed you, without hopping and skipping and jumping and screaming across the bitumen road. That's another sign. They've already got neuropathy. Neuropathy in the foot is also associated with vessel changes in the frontal lobe. So these patients can be inordinately happy, but their perception is altered. So they appear to be listening to what you say, but they've actually got damage, so they're actually not able to actually put it into praxis. So you need to give them something to read. You know, they're the patients that you say, don't walk on your foot, and they get straight off the bed. No, I won't. Straight off the bed and walk on their foot without putting their orthotics on. Okay? That's not their fault. They've got a perception problem associated with frontal lobe neuropathy. What does this wound tell us? Acute or chronic? It's chronic. It's a pilonidal sinus, isn't it? Now you can see that the granulation isn't an even colour. If we turn the light off, you could see that this is red and over-granulated, but you've got this sloughy area here. And a lot of nurses use the absorbent dressings in these wounds, and they leave particulate matter, and I'll show you a wound later on in the presentation. So particulate matter makes the granulation stick to itself. So you've got granulation growing over the top of that debris underneath that wound, and you've got skin that's migrating over. And if that patient sits on that wound, it will compress all of that, and you'll have skin that goes from one side to another, but the skin won't be in contact with the base. And you'll just have a little hole that it keeps draining out of. And it'll be smelly fluid that's leaking out of that. You need to get this patient, and they hate you for it, because they all come in, they're about 18 to 25. And here you are, a 50-year-old woman, and you've got to get them to actually bend and touch their toes to tear that tissue apart, okay? It's not going to be painful because it has no sensation. It's secondary, healing by secondary intention. Then you need to tell the patient and the family, they usually come in with a mother or a father who's completely traumatised because they're trying to clean the wound out for them, that they've got to get in underneath that overgranulation. You may even cut the overgranulation out of that wound and stop using products with particulate matter. Put something like a Mesalt. Do you all know about Mesalt? It's a cheap as chips product, and it's actually got hypertonic saline. So normal saline is 0.9%. Hypertonic saline is 4% to 9% salt. So it will draw all the fluid out of that overgranulated tissue so that you can clean the base and you don't leave any particulate matter in that wound. Sometimes the things that we do are causing harm to our patients. So think about that. Not all products need to be put onto acute surgical wounds. Now this is a wound, a suture line. What's it telling you? It's unhealthy, isn't it? It tells you that it was healthy probably a week ago because they took the sutures out. So that's a patient that's got a little bit of adipose tissue there, hasn't it? So what's happening to that patient? They're actually lying on the bed and they've got no support to that suture line, so gravity is pulling the suture line apart, and then the fluid starts exuding out that wound. You can also see that yellow fluid that's leaking out through the wound. You've got a large abdominal incision. The surgeons have actually messed around in there and affected the lymphedema, so you've got a seroma there. That's just a lymphocele, okay? And the lymphoceles actually present with bright yellow fluid, just proteinaceous fluid. And this abdomen doesn't need alginates, foams, all of the expensive dressings. This patient needs to be put into a pair of Spanx, okay? Because compression heals a lymphatic wound. So you're actually treating what's going on under the surface rather than on top of the surface. So if you support that wound, you'll get rid of that fluid that's draining out of it, and the suture line will adhere again. So at this point, you don't remove those sutures. You would actually put a dressing, just a cheap dressing, a Telfa pad, fix them all from one side of the abdomen to the other, and then tell them to go home and put Spanx on when they can. And you will find that you will get the swelling out of that belly. You'll have a patient that's more comfortable because you've got it contained and compressed, and the fluid from the lymphocele will start to circulate around the body. The lymphatic system sits just under the skin, so you can also get them. A major thing when you've actually affected the lymph nodes is to actually look at lymph drainage exercises, and your occupational therapists can give the patients exercises to open up the channels for lymphatic drainage. If you look online, lymphatic drainage exercises, very easily done. I think the Lymphatic Society even has patient handouts that you can print off from online. This doesn't need expensive dressings ongoing for months and months and months. Compression, and that will be healed in a week, okay? Treat the cause, not the wound.
Would they come back a week, and when would you take out the sutures?
In a week's time. Yeah, once you've actually created the environment for that wound to heal. So we know it's not infected because there's no redness and cellulitis. There's a little bit of erythema associated with the sutures being there too long. But you just want to actually you could use one of those dressings that got a little bit of silver, protect it from the environment, or you can use a really good dressing, Inodine, over the top, put a combine over that, Spanx, Bob's your uncle. Get them back in a week's time. Or if they're exhibiting signs they didn't have before of infection, what are the signs of infection that patients actually detect earlier on? Pain, heat, they may have rigors, pus, all of those things. So if you've got those signs and symptoms, then you'd think infection. If you've got a healthy looking wound that's draining exudate, don't think infection and that they need antibiotics. Think we need to clean the wound, all the skin, with an antimicrobial wash. We need to put the antimicrobial wash in place on that exuding suture line for 10 minutes to kill any organisms that are there. Because if you swab that wound, you would actually get organisms, won't you? If you probe that wound, what are you going to find? It's going to go for a long area. But does it need to be packed? No, because it's an open compartment that's just been weakened with the suture line because you've got fluid that's not contained and you've got a seroma that you haven't managed. So don't pack these wounds. Just compress the outside, treat the cause. You've deduced it's a seroma. Talk to your GP about that and get into compression. Cheap as chips. This wound tells us that they've had some sort of allergic response to the dressing, haven't they? So once again, you wouldn't use a dressing in that area. You can see that it's completely dehisced. So you have taken the sutures out, and unfortunately, the patient may be malnourished and the suture line has just fallen apart. You want to know what sort of surgery they've had there. If they've got bone graft under that, they need to go straight back into a orthopaedic surgeon and they'll flush that wound out. So you can contact the surgeon, let them know that this has happened. They'll need to actually see that wound again. So you do an antimicrobial soak for 10 to 15 minutes, put a dressing that's not occlusive on that area, something like a Mepor or a Zedivit Plus, and then use an old gate dressing. You know, the old style where you had elastoplast one side and elastoplast the other and shoe straps to bring it together? Because any dressing that's adhesive is going to be allergic to, the patient's going to be allergic to the tapes as well, because it's the same ingredients. Sometimes you'll have silicone, but you don't want a dressing left in place for a long time on this. You need to make sure that that's not going to get infected, because that's a lot of damage there. It's completely pulled apart. This poor old man, you know, we've got to look at the whole patient, haven't we? And, you know, a lot of our patients are refusing to go into nursing homes. And my friends and I are planning our nursing home experience now. So we're going to buy a winery. We're going to drink copious amounts of alcohol, swim in a pool, and have young men just coming and cleaning the pool out for us. That's exactly it. That's our nurses' nursing home. So these patients are in their home far too long. They're malnourished. They've got chronic diseases that are being poorly managed. They've got equipment that's damaging them. So when you get one skin tear, you're going to get a number of skin tears. So you need to think about using shin splints that they use in nursing homes, those fluffy tubular bandages over the pretibial area to protect them from that. When they've got a number of lesions on the leg, don't keep putting multitudes of dressings. Just use something like a zinc paste bandage that will just be applied from the foot right up to the knee. It moisturises the tissue and it actually protects the wound. But what's something that Carolyn Carvel has done 2 to 3 years ago to actually stop injuries to skin in our older patients, or in patients over 40, young patients as well, I'll say that. If we moisturise our skin twice a day, when we bump ourselves, we won't damage our skin. It's more resilient. So I'm pretty sure that Ego products maybe here and have a stand. Ego products are non-allergenic, and they actually have a range of different types of creams. So there are creams that sit on the surface. There are other creams that go down into the surface, humectants, that will actually moisturise and protect that skin from being injured. So go and talk to Ego about the different types of ingredients in lotions and how you wash the skin. Patients over 40, we shouldn't be using soap on our skin. We should be using oils to clean our wash, looking at QV lotions and all of that, QV wash, to maintain the pH. So it's not actually interfering with the way that our skin protects us from getting infected. And then we should use another cream over the top to stop us from actually developing damage from bumping. The effects of age, it's just wrong, isn't it? You see these young ones and you just think, oh, your skin's beautiful. Nevertheless, you know, how many of us, when we first started, we had beautiful skin. What was the first thing we were taught when we went nursing? How to bloody smoke. You know, didn't we? And we'd be out the back smoking. Shocking. And now we're seeing the effects of the sins of our youth. So when we're looking at the wounds, look at an assessment, look at it holistically. Have our patients ever smoked? They may say they've not smoked before, but are they just having social cigarettes? Have we done an ankle brachial index for our 50-year assessment for patients to determine whether they've got the first signs of some form of chronic disease, or are they at risk? Look at the factors that may impede healing, external factors that we can change. We don't debride enough in general practice. And then product selection. So the products are the least important in the scheme of wound healing. Do you hear what I say? The products are the most expensive, and yet we're focusing on education about products too much. We need to think about what's the body actually doing and work with it to get it healed, because it's extraordinarily resilient. And then plan to actually prevent these wounds from coming back, because we know that once patients have had a wound, if we don't actually treat the cause for life, the wound will break down again because it's 20% weaker than what it was before. Look at the whole patient. This is probably what I'm going to be like. At 80, I'm going to take up cigarettes. I don't want to live till I'm 150, you know. I'm going to be drinking copiously and being around swimming pools with very disgraceful people. And we're going to laugh, which will probably make me live to 150, because we know humour does work. But it's pointless telling this poor old lady to give up cigarettes because she's got a wound. So why not just give her dressings that she can manage herself, that are cheap, and, you know, look at dressings that can stay in place. Sometimes Zipsock, if you manage the edema, the Zipsock can stay in place for a fortnight. And that's just a paraffin, zinc on a tubular bandage, stay in place for a fortnight with tubular bandage over the top. Sometimes these patients love to come in and see us. So if they want to come in and see us, use Adaptic and Combine. and see them every 2 days to 3 days because you're offering them something. But think about referring them somewhere else where they're going to get social isolation. We found with our clinic, having all of our patients with wounds coming in at once, we were surprised, and we hadn't thought about it, that on the Gold Coast a lot of people are so lonely. When we started moisturising their legs after we'd washed their whole leg, they'd be ahhing like pussycats because some of them never get touched. What an indictment on our society. So let's start looking at, groups like Ellie Lindsay that sets up a leg club in the community, and there's no funding in Australia for that, of course. But if you write to the Medicare task force and say, can we get funding for leg clubs? These patients of the same age that are living independently may come, develop social isolation and cajole each other into wearing compression, which is what they do. We initially had all the wounds separated and curtains. The patients pulled the curtains back and they all talk and they look at each other's wounds and, oh, that's looking better this week. How's the compression going? All of that sort of stuff. They talk about how lovely the doctor is and how rough the old nurse is. The doctor gets a bottle of wine when the wound's healed. I get cat's bum lips. Hope I don't see you again. But some things we can change. The social circumstances we can make a difference in. Mobility. We need to actually get our patients to, if you've got wounds on limbs that have got poor perfusion and you've got no blood flow, getting the patient's family, if they're at home, to do passive exercises will actually increase the blood flow to the skin 10 times that of the patient remaining just completely exercise-free. So think about that. When we start to walk, we may use our large, great muscles take the oxygen from the vessels. So you don't want the patient walking around when they've got a wound because you want as much oxygen getting to the skin as possible. So think about immobilisation and managing the ischemia. Look at the wound, looking at the right information. We can heal all wounds, but should we? So this is a book that's been dropped on this foot, and I'll show you a foot later on whereby it was healed, but inappropriately because as the wound starts to contract, you can see that the tendons have been damaged there. As the wound contracts, the second and third toe will elevate, and those patients will never be able to wear shoes again. So when the foot has been damaged like this, sometimes it's better to send them into the hospital to an orthopod for skin grafting, so then they've got a functional foot. We know we can heal these wounds, but is it in the patient's best interest? So think about our functionality. If the tendons are impaired, we need to get that managed better. We need to look at how we diagnose and how we document our wound. So when we look at this tissue, we can look at it and it will give us a picture. But until we look at the whole patient, it's not going to make much sense, is it? It's just like looking at a pizza. Useless. You've got to look at the whole patient and figure out what the disease process is going on there before we start putting dressings on this slice of pizza. This is where we bring value to our chronic diseases in general practice. We need to look at what we do with care planning and knowing our patients and getting our patients onto case conferencing. I know that case conferencing is not used enough. Every patient with a wound, you should be doing a case conference. Diabetic wound, who should you get for a diabetic wound in the community? Absolutely. And sometimes no wound is too small to actually be sent to a high-risk foot clinic. There's research out there to show that small lesions lead to renal impairment in a patient. So why not get these patients into the high-risk foot clinic in the hospital sooner rather than later? As soon as that tissue is impaired, we develop a working relationship with the high-risk foot clinic. They know that you know what you're doing. You don't want to send them a wound that's down to the bone. There's a test called a 5-cent CAT scan for diabetic feet. What's the one thing that you do with a diabetic foot early? Probe. If you probe and you hit bone, 90% of wounds that have been there longer than 2 weeks over a bony prominence have osteomyelitis. So your management is going to focus on antibiotics rather than dressing products, isn't it? So we need to think about that. No wound is too small to be referred to a high-risk foot clinic or to be connected via telemedicine, okay? Because not all patients will go into hospital. Frightens them to death. And they are at risk of dying early, prematurely.
About that
Yeah,
facilities then.
it's frustrating.
We don't have, I mean, you know, we have to treat the ulcer. We can't refer it because if we can refer it, it's a 6-month or 3-month, we don't even have a high-risk diabetes.
There are telemedicine. The CRC in Brisbane has a telehealth capacity linking in with a vascular surgeon. They're out of Spring Hill. It's called the Wound CRC. You can do a search and they will do telemedicine, and there is an item number for that, for the GPs, GP nurses and the CRC. And there are things that you need to do. If you don't have podiatry, you've got to think about relieving the pressure. And I'll be talking about how the foot changes associated with diabetes. And just knowing what the patient needs, you can actually get splints that we can make up by heating them and then moulding them around the patient. Very easy to do. That even in the country, if you've got a company that sells a product, you've got a company that will teach you how to apply that product. And that's what we need to be taking more responsibility for, not just saying, no podiatrist here. So your role is to shave that hyperkeratotic tissue back, offload the pressure, get them into orthotics, save that foot. The most important thing about wound management is thinking about the HIDE acronym. History. What's happened to that patient? Where have they been in their life? What's the family history? Examination. You can generally tell people have had venous disease. Did you know that people that have had a DVT, if they're not wearing compression garments, in 10 years' time will probably develop a venous ulcer? So if you can tell your patient where you need to wear compression for the rest of your life, or go to a vascular surgeon and pay $4,000 to have endovenous ablation. But the Medicare task force is ruling now, if all of you write to the Medicare task force and say endovenous ablation needs to be on the Medicare item numbers, patients can get that done free and stop venous leg ulcers from coming altogether. Let's get onto them. We've been educating for years, getting nurses and GPs to write to the task force for the last year or so, and they're looking at wounds and management in general practice. We want an item number for debridement. We want to look at endovenous ablation, because not every patient can afford $4,000 a leg. I would, because I hate stockings. And yet I wear no stockings and I get swelling and I do nothing about it. But we are at risk. Look at the investigations that are necessary, diagnosis and indicators. Talk to your GPs about what's going on and what you need to do, other than just dressing products. GPs want to work closely with you. They don't always want to tell you that they don't know they don't have as much information as you about the products, but they sure as heck know a lot about the diagnosis and the underlying factors that you can manage together. And that's what you need to do. Because a nurse that costs the GP clinic a lot of money on dressing products without getting the outcomes is actually a waste of time, isn't it? We should be using our care plans. We should be working with the GPs and knowing our patients, so that we know if they've got rheumatoid arthritis or diabetes, or they're on chemotherapy, that we need to actually get them through that inflammatory response by nursing initiatives such as debridement quickly, rather than dressing products. Venous leg ulcers should heal 25% in a 4-week period. And as I said to you before, a major goal with venous leg ulcers is 12 weeks they should be healed with compression. If you can get endovenous ablation, they will heal a lot quicker because you're treating the disease underneath. Wounds like this, we've all got husbands that go out and fish, and, they go fishing over the rocks in thongs, they have a few beers, cut themselves on the oysters. If there's not pain and they're able to stay out of the hospital, out of the doctors for a number of days, they've got neuropathy here. You can see this hyperkeratotic tissue around the wound. That's because they're walking in a different fashion. At the 50-year assessment, you should be taking the patients into the room, looking at their feet, taking their shoes and socks off, and looking for signs of callus. Okay, now you're looking a little bit tired, and I'll just get you to stand up for a second. With a diabetic patient, they get changes that lead to callus formation on the metatarsal heads because they're walking in an altered fashion. Now take a step and feel how you take a step off the heel, you balance then off the metatarsal head, and then you offload off the toes. So it's a 3-point rock. Okay? When patients have long-standing diabetes and the vessels are calcified, The bones drop because the tendons become weak because of the ischemic changes. And they walk with claw toes. See how it feels when you walk with your toes elevated. Lift your toes up and take a step. So you're not walking in a rocking fashion anymore, are you? You're actually walking on the heel and the metatarsal heads. It causes pain. We would stop walking because it causes pain. Diabetics don't know that they're actually causing damage to their tissue, and it will show up as callus or fissures on the heels because the tissue is being damaged. They're the signs you need to look at the 50-year assessment, and that's a foot that's at risk of a chronic disease. You get paid for that. And what do nurses worry more about than payment? Quality of outcomes. We've prevented a patient losing their foot because we're actually going to tell them how to moisturise their limb, how to check their foot, how to wear proper footwear, how to wear silicone socks. And I'll talk about the different systems that are altered in a diabetic foot later on, and how important little things like moisturisation and silicone socks can make to your patients. Okay, so wound depth. You can sit down now, but always remember that. Watch how people walk. Warning signs that you need to do a 50-year assessment or earlier. A patient that's at risk of a chronic disease is by how they walk. If they're walking in an altered fashion, if they've got swelling in the lower legs, if they're complaining of pain that's stopping them from walk, they're at risk of chronic diseases because of sedentary lifestyle. Dressing products aren't going to change that, but we can change that by stockings, implementing compression management, a vascular referral, but also orthotics in the foot. We do a great job. Wound depth. When we're looking at the skin is all excoriated, isn't it? It may be not that the patient is lying down. Sometimes the patients, if they're incontinent, they're putting creams on that have got paraffin on the skin, in their dressing product, in the creams. Paraffin will stop incontinence pads from absorbing urine. So they were actually sitting with the urine sitting on top of the incontinence pad that's burning the skin. So you need to look at your incontinence pads, and the instructions will generally tell you what types of creams the patient can use with an incontinence pad. Doesn't need expensive dressings. You just need to get a better cream on that tush, okay, and educate the patient that, they're damaging their skin because they're using inappropriate creams. But, a stage 2 is basically where the skin is mainly intact, but you've got areas where the skin is damaged. Superficial and partial thickness. You've got superficial around the edges. It's actually epithelializing here. You've got a granulation that's got skin migrating over it. But you've also got slough in the base. So you want to heal, you want to get rid of the slough, and you can see that whatever you're putting on that wound is actually healing because the slough is diminished on one side. And when you look at the surrounding wound, you've actually used a little bit of iodosorb, I would say. And these wounds are difficult. You wouldn't use adhesive dressings there because they just don't stick. Sometimes just getting the patients to wear those little bike shorts that they get with incontinence pads, those stretchy gauze things. It sits in between the natal cleft and holds the dressing in place. So you could just put a bit of iodosorb and then a melolite, hold it in place with those incontinence shorts, and get the patient to change that as they need to. Because whenever they defecate, they need to clean that wound, don't they? They need to clean it. Cheap. Diabetic heel. That doesn't happen overnight. Okay, that patient's probably been coming in and seeing you, and you've never taken their shoes and socks off. And sometimes the first sign that these patients know that they've got a wound is when they look at their socks and there's blood and slough in the wound. A wound that's got that amount of callus over it, you can probe underneath that callus and all of that skin won't be in contact with the margin. That'll all be flapping off. So you've got to shave that back. Shave all of that hyperkeratotic tissue. It doesn't have any nerve cells. Just shave it gently like you'd shave an orange. If you're not confident, talk to people in your local environment that can actually help you, teach you how to do it. Podiatrists can teach you how to shave the hyperkeratotic tissue. If you're in the city and you're out bush, find someone in the city, plan, and ask them, can you teach me how to debride? Most of your nurse practitioners in your local hospitals do clinical competencies on debriding. So contact them and make an appointment to go in and be taught how to do clinical competencies in debridement. Or utilise a debriding device, which I'll show you later on. But this wound goes right down to the bone. If you were to probe that with a metal probe, you've got it down to the bone. So you've got osteomyelitis, and you're probably going to lose that foot. Okay? You don't need expensive dressings. Superficial wounds don't exudate, that you would macerate the tissue. You've got a catastrophic foot at risk of dying. Poor old man in the nursing home, you know, one night normally didn't cry, cried all night. No one looked, he was positioned on his scrotum. No matter what dressings you put on that wound, the damage that was caused by that one night of him screaming and positioned incorrectly led to this catastrophic damage. He needed an orchidectomy and surgical repair. He doesn't need dressing products there. Poor old man. Look at our patients, listen to their history. What caused this damage? Are they complaining of pain when previously they haven't? Not all of our patients are histrionic. You know, pain is significant. We've got to treat our patients with care and respect as if they were relatives of ours. Probe the wound. The most common cause of this type of damage in a diabetic foot, have a guess, what causes that? On holidays. What's the first thing you do when you know you're going overseas or going on a holiday? Brand new shoes. Diabetics should never buy brand new shoes before getting on a plane, because you get into the plane, the pressure reduces the swelling, you get off the plane, in new shoes, your foot swells and you can't feel. So you're left with all of this pressure on the adipose tissue. You come home in 2 weeks' time and you've got little black lesions, and they'll eventually come off and just exude smelly fluid that are all connected because the adipose tissue has been damaged by that plane flight. So tell your patients, you need silicone socks, you need compression hosiery, class 1 compression on a plane, do not wear new shoes, and get that shuttle bus to take you off the plane to where you need to go to pick up your bags and catch a taxi. Do not walk until the swelling is down. Tell them they're going to get swelling from the plane. We need to educate our patients. We don't manage this with dressing products. We probe it, and if it probes to bone, you need to go on to an antibiotic regimen for osteomyelitis. We're getting these patients out all the time early. You know, they've got drains still in place, large wounds. If a hospital is discharging these patients, we know we can heal it, but the hospital needs to supply us with the dressing products. If it's a hospital avoidance program, it's a collaborative between the hospital and the nurses in the GP clinic. Ring them up and say, you need to be supplying me with a vac to actually get this wound healed. Otherwise, this patient is going to be on your books for 12 months. We know we can do it, but can we afford it? Can the patient afford those dressing products to save the hospital $1,000 a day? Do you know that it saves the hospital $1,000 a day to discharge those patients? So when they've got wounds that will take a couple of weeks to heal, you've saved all of that money. They can actually have an amount of money that they can supply dressing products for those patients, that they're comfortable. And compression as well. Patients that have had this type of surgery should actually be fitted with compression garments on the abdomen. So, healthy tissue, the skin, may not realign and become the same colour as the surrounding tissue, but you know that that skin is fragile. There's a divot there, so it's been damaged down to the dermis, maybe down to the bone. This patient needs to know they need to use humectant moisturisers that really keep it moist, stop it from breaking down, because this tissue will dry out and split, and then you'll have a wound recurring all the time. Okay, this is the foot that I'm talking about. You see that toe? It's healed in the community, but should it have been? No, because the tendon was damaged. So you've got this beautiful red granulation, and I've only used this because you can see the different colours in the granulation. See here where it's purple and a dry looking? That's one layer of skin cells. This is 5 layers there, but you may have 3 layers there. The edges are showing, it's a bit dry. Okay, you've got islands of epithelium, full skin there, but in between you've got dry areas. That's 1 or 2 layers of skin. So you don't want to actually aggressively clean that by rubbing it, because you'll get that stratum basale floating around the skin. You just need to actually flush that wound, because it's not infected. Flush it, or have a soak, Prontosan soak left in place, or saline soak. Saline doesn't kill the organisms, and then just get the plastic forceps, break them in half, and get rid of this little bit of slough there. Put betadine in between the toes, betadine soaked gauze, wrapped up and snaked in between the toes, because we know the most common cause of infection is organisms from between the toes that infect the wound. Okay, so we need to be looking, washing the whole limb down, washing in between the toes, getting rid of the organisms. How do we kill organisms? Contact time with an antimicrobial. Pointless just spraying in between the toes. You've got to have a gauze soaked wick in betadine in between the toes and left in place.
So betadine's back in vogue?
Absolutely. If you look at all the new information, and I've got all the readings for you, Europe are using acetic acid, Europe are using betadine, more betadine products, but slow release. So it's not, it's slow release iodines. And this type of wound, oh, don't you love it when a patient, you've got this wound ready for debridement. You can just peel the slough away from the base, break those plastic forceps up, use the serrated edge and try and lift it up, and where you lift it up, get some metal forceps and pull it off, okay? You have a great afternoon removing that. You can have you just love it because you make such a difference. Fibrotic slough is not ready to debride, but this cheesy, pasty looking slough, the white cells have actually done their job. They're actually weakening the attachment of the dead tissue at the top to the wound base below. So in between, all the fibrils have been broken down, so the attachment is weaker. If you actually put something like Prontosan on, and Prontosan has an antimicrobial, but it's also got a detergent in it. You leave it on for 15 minutes and the detergent will actually weaken the attachment of that dead tissue to the wound base further. It's just like when you go camping and you forget the dishwashing liquid. You can still wash the dishes, can't you? But it's harder. So that's what a detergent will do, and that's why Prontosan is so efficient. Dead tissue never rehydrates. It needs to be removed, and possibly that leg. So this was a motor vehicle accident. They had their leg squashed under the dashboard. The leg looked normal. You give it a bit of time and the body will declare what's happening. Just the same as people that jump off a fence or something. The tissue looks good, but after a while you'll start to see a black area. That's not because of the dressings you put on it. That's because of the damage that was done by the trauma initially. Okay, so you've got to think about, this patient may have had an angiogram, for example, and a thrombus has been mobilised, and the area of the artery is just blocked. That may come in as a blue foot. You don't keep it in your general practice, do you? You send them straight away to the hospital. All blue feet need to be investigated. But in the hospital, that may well turn up. This green tissue, absolutely. You want to clean it off, you want to kill the Pseudomonas, you want to alter its environment so it's not attracted to that environment. Okay? Aggressive cleaning, debridement, get your forceps out. This is a lovely, cheesy, horrible slough. You can get rid of that, cut it off. If the patient's in pain and afraid of you, put the lignocaine on. Leave it for 20 minutes. Put betadine, soak gauze if they're not allergic to it, wrap it in Glad Wrap, come back and debride it. It's morning tea time. Now your heads must be thinking, what the hell has this woman been ranting and raving about? But after morning tea it comes back and makes a little bit more sense, okay?